Okay, so we are talking about the parts of the respiratory system. We have talked about the nose, external nose, nasal cavity, the structures in the nose. We have talked about that. Then we have talked about different parts of pharynx, right? Nasopharynx, oropharynx, laryngopharynx. Important information about those three parts. So larynx is a cartilaginous structure. Mainly it is formed by cartilage and located in front of the esophagus. So larynx is a cartilaginous structure located in front of the esophagus and below the pharynx. And larynx has a number of cartilages or cartilaginous structures. All cartilages except the epiglottis of the larynx are hyaline cartilage. So only epiglottis is formed by elastic cartilage. Other cartilages of the larynx are hyaline type cartilage. So we'll see what are the other cartilages. The largest cartilage is the thyroid. So thyroid cartilage is the largest cartilage of the larynx, which is a hyaline cartilage. And then cricoid cartilage is the second largest one. So second largest one is the cricoid cartilage. And then there are three pairs of tiny cartilages. What are those small cartilages? Those are paired, arytenoid, cuneiform, and corniculate. Those are in pair, 2 in number each. Okay, so except the epiglottis, other cartilages are hyaline type of cartilage. Epiglottis is elastic. And epiglottis covers the laryngeal inlet or opening during swallowing. When we swallow the food should enter into the esophagus, not into the larynx. That's why the opening of the larynx is covered by the epiglottis. Epiglottis moves down like this and covers the opening of the larynx. Here in this picture, you see those cartilages from the front. From the front, you can see some of those cartilages. You see the epiglottis at the top, and this is the largest one, the thyroid cartilage. This is the second largest one, cricoid. Okay, and tiny cartilages you can see better from the back or the side. From the front, you don't see those cartilages, small cartilages. Now, one membrane and one ligament are present in the larynx. This membrane that connects the thyroid cartilage and thyroid bone. You know the thyroid bone. So this is called thyroid membrane. Very simple, connecting thyroid cartilage and thyroid bone. So that is thyroid membrane. It is a connective tissue membrane, and the ligament that connects the cricoid and thyroid, that is called cricothyroid ligament. Okay? So this one is ligament, this one is membrane, and they have been named after the structures they are attached to. Okay, so this is the front view of the larynx. And the laryngeal prominence, you know that Adam's apple, that is the thyroid cartilage. Because of thyroid cartilage, we see that prominence there in the neck. Okay, this is the larynx. You are looking inside the larynx from the side, and you see those small cartilages. This is the corniculate, arytenoid, and cuneiform here. So cuneiform, corniculate, and arytenoid. This is one side. Those are also present in the other half. So 2 in number. The thyroid cartilage is sensitive to the male sex hormone testosterone. So this cartilage, thyroid cartilage, interesting thing is that it is sensitive to testosterone, the male sex hormone, and that's why at puberty, when the male sex hormone starts to release, the thyroid cartilage grows, gets bigger, and that is the main secondary male characteristics, Adam's apple or laryngeal prominence. Okay, inside the larynx, you will find vocal ligaments. And vocal ligaments form the vocal folds. Okay? Vocal folds help in the production of sound. You know that, all of you. And the opening between the vocal folds, that opening is called the glottis. So glottis is the opening in between the vocal folds. So we have two vocal folds like this. This is one vocal fold, this is another vocal fold, and the opening in between, that is the glottis. Okay? So we can change the size of that opening by controlling the vocal folds. Okay? We can change the size of the opening. And by changing the size of the opening, we can change the frequency of our sound. Okay? The frequency of the sound. And when the vocal fold vibrates, that produces the sound. What happens when we talk or sing? First we inhale the air, take the air inside the lung, and then we adjust the vocal folds as we need, and then suddenly we release the air from the lung, so that air will hit the vocal fold from the bottom, okay? Because coming out from the lung and vocal folds are in your larynx, so the air will hit the vocal folds, and that will cause the vibration of the vocal folds. Make sense? So that vibration will produce the sound. And the frequency of sound depends on the frequency of the vibration. Okay. So that's how we produce the sound. Then that is the basic sound. That sound from your larynx that comes to your mouth, inside the mouth. And inside the mouth, what we do, we modulate that sound. We modulate that basic sound. And that part we actually learn how to do, right? From our childhood, we learn how to modulate that sound and produce it as speech or language. Okay? So basic sound we all produce like very same, very similar. Like oh, that kind of sound. Then that sound comes to your mouth, into your mouth, and we, by using the tongue, our other structures of the mouth, we modulate that sound and present it as speech. Here you see inside the larynx, here the vocal folds are closed. The glottis is closed, so there is no opening. And here the glottis, this is the glottis, is open. The space or opening between the vocal folds. So we can see that we can close or open the glottis. Change the size of the opening or glottis. Okay, so that's about the larynx. Then next structure is the trachea. Trachea is the air tube. In common term we use air tube, that is the trachea. And if you see the wall of the trachea, there are 3 layers in the wall of the trachea. What are those 3 layers? Innermost layer is the mucosa. And the epithelial lining of the mucosa is pseudostratified ciliated columnar epithelium. That means those cells, epithelial cells, have cilia. And then under the mucosa, next layer is the submucosa. Sub means below, so below the mucosa. And submucosa is formed by connective tissue. And within the connective tissue, you will find 2 types of cells, glandular cells, serous cells and mucous cells. Together we say seromucous cells. So serous cells will secrete serous fluid, and mucus cell will secrete mucus. Serous is watery and mucus is more sticky, okay, fluid. Then the outermost layer is the adventitia. And adventitia is a connective tissue layer that contains the laryngeal cartilages. The tracheal cartilages. So tracheal cartilages are present in the outermost layer. And tracheal cartilages are C-shaped cartilage, not complete circle, C-shaped cartilage. That means the cartilage has two ends. Okay, this part is open. So a number of C-shaped cartilages like this, they form the trachea. Okay. Now, I may ask you that tracheal cartilages are located in which layer? They are located in the outermost layer, in the adventitia. Okay. Seromucous cells, glandular cells, are present in which layer? In the submucosa, right? And the innermost lining is the mucosa, and the epithelial lining of the mucosa is the pseudostratified ciliated columnar. Now, the tracheal cartilages are hyaline type cartilage or hyaline cartilage. Okay. So tracheal cartilages are hyaline cartilage and C-shaped cartilages. And since the cartilages are C-shaped cartilages, they have two ends, and those two ends are connected by smooth muscle fibers. So this is front of the trachea, this is the back of the trachea. So if you look the back of the trachea, you will see smooth muscle. Make sense? The C-shaped cartilages are like this, from the front like this, and in the back, two ends are connected by smooth muscle. So if you look the back of the cartilage, trachea, you will see smooth muscle. That is the trachealis muscle. Okay, and the last cartilage is called the carina. So carina is the last tracheal cartilage. My favorite, I may ask you in the test. So carina is the last piece or last cartilage of the trachea. So from the carina, we can say that trachea divides, right? Because we know that the lower end of trachea divides into bronchi, primary bronchi or main bronchi, right and left. So from the carina, the trachea divides into bronchi. Here you see a cross section of trachea here in the front, and this is esophagus. Since we are talking about the respiratory, we'll see the trachea. So three layers. This layer is the mucosa, dark red, and this is the submucosa, and this is the adventitia. So again, in the mucosa, you see the cilia, pseudostratified ciliated columnar epithelium, and then in the submucosa, you see the glands, seromucous glands, the seromucous glands, and in the adventitia, the main thing is the presence of tracheal cartilage, C-shaped cartilage. Now, in the back, you see the smooth muscle here, that is the trachealis muscle. And behind the trachea, we have the esophagus. This is the real histology of the wall of the trachea. So you see those three layers. Okay. Now, we'll talk about the respiratory zone. You know that the respiratory system has two parts, the conducting part and the gas exchange or respiratory part. Conducting part only help the gas to move from one place to another place, and in the respiratory part or respiratory zone, which is also called gas exchange part. Through the wall of this part, exchange of gas takes place between the blood and the respiratory system. So what are the parts of the respiratory zone? Respiratory bronchioles, alveolar duct, and alveolar sacs. About 300 million alveoli accounts for most of the lungs volume and are the main site for gas exchange. Among those three parts, gas exchange mainly takes place inside in the alveoli. So alveoli are the structures where mainly the gas exchange occurs. Okay? Small amount of gas exchange takes place through the wall of the respiratory bronchiole and alveolar duct, but mostly gas exchange takes place through the wall of the alveoli. So here you see those three parts: respiratory bronchiole, alveolar duct, and alveolar sac. And alveolar sac looks like, grapes. When you buy the grapes, you know that the grapes are attached to the stem, right? So like many air balls are attached to the alveolar duct. There is a duct and many air balls are attached to that, and that is the alveolar sac. So cluster of air cells or air balls. That's the sac. Now, if you see the wall of the alveoli, you'll see many pores or holes are present in the wall of the alveoli. Those are called alveolar pores. And gas exchange takes place through the wall of the alveoli. And the structure through which the gas exchange occurs, that structure is called the respiratory membrane. So we will now talk about the respiratory membrane. Respiratory membrane is about half micrometer thick air-blood barrier. That means if this is the respiratory membrane, in one side you have the air in the alveoli, and in the other side you have the blood in the capillaries. Okay, so the barrier between the blood and the alveolar air. So if this is an alveolus, this is the wall of the alveolus, and in the outer surface of the alveolus you have the blood capillary. All alveoli have blood capillaries attached to the outer surface. Okay, so here you have two structures, right? This is the alveolus, and this is what? The red one is the, what is this? Blood capillary. Very good. So now this is the respiratory membrane. So now we can say that respiratory membrane is formed by the wall of the alveolus and the wall of the blood capillary. Can you say that? Okay. So if this is the blood capillary, your blood is here, and air is here. Here is the air in the alveoli, here, and here is the blood inside the capillary. Okay. Now this is the respiratory membrane, which is formed by the wall of the alveolus and the wall of the capillary, blood capillary, and the gas exchange takes place through that structure. That's the respiratory membrane. Okay. I forgot my wallet. Okay. Okay, so that is the respiratory membrane, very simple, formed by the wall of the alveolus and the wall of the capillary through which the gas exchange occurs. Now, which way the gas moves? We know that from the lung or alveolus, the gas, which one goes into the blood? The oxygen, right? Because blood goes to the lung to get the oxygen. So from here, the oxygen will go there, and from the blood, the carbon dioxide will get into the alveolus. So that is the gas exchange. Now, the respiratory membrane has 3 layers: alveolar epithelium, basement membrane, and capillary endothelium. Okay? We know that respiratory membrane is formed by those 2 structures. So now we'll see individually those 2 structures. If you see the wall of the alveolus, it has 2 layers. What are the 2 layers? One is the basement membrane and the alveolar endothelium, epithelium. So alveolar epithelium, epithelial simple squamous type cells. So those are the 2 layers of the wall of the alveolus. Okay. So this is what? Basement membrane, and this is the epithelium, alveolar epithelium. Okay. Now we'll see the structure of the blood capillary wall. The blood capillary wall has 2 layers: basement membrane and the capillary endothelium. Capillary endothelium. So this is the wall of the capillary, this is the wall of the alveolus. So again, basement membrane and endothelium. Endothelium. Okay. Now, since they are attached to each other, we will attach these 2 together. Just this one, we will flip, because this is the basement membrane. Now, basement membrane here, and then this layer, endothelium of the capillary. Okay. So this is the respiratory membrane. Now, this layer we can say fused basement membrane, since both are same. Okay. This one is basement membrane of the capillary wall. This is the basement membrane of the alveolar wall, and we can say that this is the fused basement membrane, since same structure. So how many layers we got? 1, 2, 3. Okay. So those are the 3 layers of the respiratory membrane. Okay. Here you see that the outer surface of each alveolus gets attached to the capillary, blood capillary. This is very important. That means we have millions of alveoli, but all alveoli has capillaries attached to the outer surface. Make sense? So all alveoli has capillaries attached to the outer surface, and that is very important because the gas oxygen will be taken into the blood from the alveoli, and blood must go there. If in the outer surface of the alveoli there is no capillary, then gas will not be able to enter into the blood. To ensure sufficient gas exchange, we need the capillaries attached to the outer surface of the alveoli. Okay, that's why you see very nicely all alveoli has capillaries attached. Now, in the wall of an alveolus, you will see 3 types of cells. 3 types of cells we see in the wall of the alveolus. What are those 3? The main type of cells are the type 1 cells. So these are the main type of cells. Those are called type 1 cell of alveolar wall. Okay. Then type 2 cells are surfactant secreting cells. These green cells, These are type 2 cells. Those are also called surfactant secreting cells. Surfactant is a fluid present in the wall of the alveoli. So that fluid is secreted by surfactant secreting type 2 cells. Okay? And then we have, do you have any question?
What does it do?
Secrete the surfactant. And surfactant is what? A fluid.
Yes.
A fluid, okay. So surfactant secreting cells will secrete surfactant. And another type of cells are present in the wall of the alveoli. Those are called macrophages. Okay? So those are 3 types of cells present in the wall. Type 1 is the main type. Most of the cells are type 1 cells. Those are simple squamous type cells. And type 2 cells are few. They secrete surfactant. And type 3 are macrophages. They are also few. But the presence of macrophages is very important. Why? Because you know that 24 hours, we take the air from outside, right? From outside, the air goes inside the lung. That means inside the alveoli. The air is going inside the alveoli, right? Now, a lot of microorganisms are present in the air, right? So, the microorganisms are entering into the lung, into the alveoli. And the macrophages, presence of macrophages is very important because they can engulf, eat the microorganisms or the dark particles that are going inside the lung. That's why all alveoli in the wall you have macrophages. That is very helpful. Okay? Otherwise your lung will get infected very easily. Okay. So I may ask 3 types of cells in the wall of the alveoli, and are those 3 types of cells. Okay? Now we'll talk about the lung. We have 2 lungs, right and left, and each lung has a pointed part, and that pointed part is above. That is called the apex, the superior tip. And then in the bottom is flat. The bottom of the lung is flat, and that is called the base. Okay, that's the inferior surface that rests on the diaphragm. So the lungs just rest on the diaphragm. Diaphragm is a flat muscle, you know, that separates the thoracic and abdominal cavity. Right? So the lungs rest on diaphragm, the base part attached to the diaphragm. Then hilum is the indentation in the lung through which the bronchi and blood vessels and nerves enter into the lung. So hilum is present in the medial side, that means towards your body, medial side of the lung, towards the midline, and it is an indented part in the medial surface of the lung where the bronchus and blood vessels and nerves as well as the lymphatic vessels enter into the lung. In left lung, you have a notch that is called the cardiac notch, and that notch is present only in the left side, left lung. Why? Because we know that your heart is located in the left side, right? So to provide room for the heart, you have a notch in the left lung that is called the cardiac. Cardiac indicates the heart. That's the notch. We will see the differences between right and left lung. Left lung is smaller and narrower. You also write down narrower than the right lung. Okay? So left lung is smaller and narrower than the right lung. Left lung has so left separated by a fissure, that is the oblique fissure. Okay? The right lung has 3 lobes separated by 2 fissures. What are those 2 fissures? Oblique and horizontal. Or horizontal fissures. And cardiac notch is present in the left lung. Cardiac notch is absent in the right lung. So if I ask you in the test, I can ask in the lab as well as in the lecture exam. In any of those exams, I may ask that tell me 3 or 4 important differences between right and left lung. Okay? So you can say left lung is smaller and narrower than the right. Left lung has how many lobes? 2 lobes. So how many fissures? 1 fissure. There must be 1 fissure that separates into 2 lobes. And right lung has 3 lobes, 2 fissures, and right lung is broader than the, or wider than the left lung, and cardiac notch is present in the left lung, not in the right lung. Okay. So here you see the lungs in the thoracic cavity, and this is the apex, and this is the base, and this is the diaphragm. So base of the lung rests on attached to the diaphragm, and apex is the pointed part. And now you see in the right lung you have 2 fissures. This is the horizontal fissure, and this is the oblique fissure, right? So 3 lobes: superior lobe, middle lobe, and inferior lobe. And this is the left lung. This is the cardiac notch, and this is the heart. Because of the heart, you have a notch there, and there is only 1 fissure. That's the oblique fissure that separates the lung into 2 lobes: the upper lobe and superior lobe and inferior lobe. Okay. The pulmonary circulation, we know that pulmonary circulation is low pressure circulatory system, and pulmonary arteries deliver venous blood, and pulmonary veins carry the oxygenated blood. Pleura. Pleura are connective tissue covering of the connective tissue coverings of the lung. Like your heart is covered by pericardium. Your lungs are covered by pleura. And pleura has 2 layers: the parietal pleura and the visceral pleura. The parietal pleura is attached to the inner side of the thoracic wall. So if this is the wall of your thoracic wall or chest wall, here is your lung. This is the lung. Okay. So the pleura has 2 layers. One layer is directly attached to the lung, outer surface of the lung. Directly attached. That's the visceral pleura. And the pleura has another layer like this, which is attached to the inner surface of the chest wall or thoracic wall. So that is the parietal pleura. So this is the parietal pleura, and this is the visceral pleura. Okay, so it has 2 layers going like this, that. Okay, and there is a space in between those 2 layers, and that is called the pleural cavity, which is filled with a fluid, lubricating fluid. That's the pleural fluid. So very similar to your pericardium, right? Pericardial cavity, pericardial fluid. In case of pleura, the pleural cavity filled with the pleural fluid. Okay. And we know that the lungs, when you take the air, lungs expand, right? And when air gets out, your lungs squeeze, gets smaller. So during the movement, because of the presence of fluid between 2 layers, the friction does not occur, doesn't take place. Now in pleuritis, there is a clinical condition. You know that pleuritis, what happens? The fluid here, two things can happen. The quality of fluid may get bad. So you know that fluid is lubricating fluid, but if fluid gets a lot of water, then the slipperiness of the fluid will get less, right? So the friction will occur between two layers. You will feel pain. That is one thing. Number two, also in pleuritis, what can happen? The amount of fluid gets less. So two members come close to each other and friction occurs during your breathing. So in pleuritis, you will feel severe, sharp pain because of the friction of the layers, the visceral and parietal layer. Friction will occur. That will cause severe pain. So pleuritis is the inflammation or infection of the pleura, that membrane. Now we'll talk about the mechanisms of breathing. How we breathe. You know that the breathing has two phases, inspiration and expiration. Inspiration is taking the air or entering of the air into the lungs, and expiration is the exhaling the gas out, exiting of the gas from the lung. So inspiration is taking inside and expiration is throwing the gas to the outside. Now, to understand the mechanisms of breathing, you need to know the pressures in three locations inside your thorax. What are those pressures you need to know? One pressure is outside of the body, that's the atmospheric pressure in the atmosphere. At the sea level, we live in the sea level. At the sea level, the pressure is 760 millimeter of mercury at the sea level. Okay, that's the pressure of the gas. Now, intrapulmonary pressure, also called interalveolar pressure. That means inside the lung, inside the alveoli, the pressure of gas is not fixed. Just know that is not fixed. It varies slightly, goes up and down. Okay. Then intrapleural pressure. That is the pressure here inside the pleural cavity. So this is interpleural pressure inside the pleural cavity. You know what is pleural cavity. So here is the intrapleural pressure. Okay, and that pressure is always negative. That means less than, negative means what? Negative means negative compared to interpulmonary or interalveolar. Okay, so always less than what? Interpulmonary. So you got three pressures. I am repeating again. One is the outside of the body, right? One is outside of the body. That is the what? Atmospheric pressure. What is that pressure? That is fixed. 760 millimeter of mercury at the sea level. If you go on the top of the mountain, that pressure goes down. You know that. But at the sea level, that pressure is 760. So outside, if this is your outside of the body, 760 millimeter of mercury. Okay, that's the atmospheric pressure. Now another pressure is inside the lung, inside the alveoli of the lung. That is called intrapulmonary pressure or interalveolar pressure, and that pressure is not fixed. I have measured that pressure goes up and down slightly. Okay, so not fixed. And interpleural pressure is always less than interpulmonary pressure. So this pressure is always negative. Negative. Okay. Now just remember that. Then we will see what happens. When we inhale the air, what should happen? The outside of the body, we have pressure 760, right? 760 millimeter, right? In the atmosphere, in the air. And Now, inside the lung, interpulmonary pressure should go up or down when we take the air inside. Just think that air will go, always remember, air will go from high pressure to the low pressure. That is simple, right? Like when the tire of your car gets punctured, right? The air gets out because the pressure is high inside the tire. So the air will always move from high to low pressure. Now you tell me, the pressure when the air goes inside the lung, the pressure in the outside should be more or less than inside? More, very good. The outside pressure should be more, right? So from outside the air will go inside. So interpulmonary pressure should go down during inhalation. Now you tell me, when we exhale the air, interpulmonary pressure should be more or less than outside? Interpulmonary should be more, right? Because always gas will move from high to low. So gas is getting out, right, from the lung. So the pressure in the atmosphere is less than inside the lung. Make sense? So that is very simple. You need to understand. That's why I told you that interpulmonary pressure is not fixed. It is changing. Sometimes it's getting, when we inhale the air, it's getting less. It is going down, right? When we are exhaling the air, it's going above the atmospheric pressure. So slightly up and down, that will cause the air to get in and out. So what is that slight difference? When we inhale the air, the interpulmonary pressure when air gets in is 759. Very little, 1 millimeter less, right? Small difference. So which way the air will move now? From here to here. Make sense? Okay. Now this is inhalation. When we exhale during expiration, that pressure goes 1 millimeter up. So basically 1 millimeter up and 1 millimeter down. That causes the inhalation and exhalation. Okay? Now you see here the pressure, this is the interpleural pressure, is always less than interalveolar pressure or interpulmonary pressure. Why it is always less, like about 4 or 5 millimeter less? Why it is less? Because this negative pressure here will keep the lung expanded. Now if the pressure is more here, it will press on the wall of the lung. Make sense? If the pressure is more here and less here, the lung will collapse. Make sense? Yes.
Okay. Where is the 759 pressure? I missed that part.
Okay. When you inhale the air, okay, inside the lung, your pressure becomes 759. When you take the air inside, that is needed because inside the lung, your pressure should be less than outside. Make sense? Then only the gas will move inside the lung. Is it clear? So during what? Inhalation. Very good. During inhalation, before the inhalation, your pressure inside the lung should be less than outside. Then the gas will get in. Make sense? Now, when you exhale the air, then the pressure should go up. Is it clear?
So does the change in pressure happen from diaphragm?
We'll talk about that. Just know that the inhalation and exhalation. Okay? During inhalation, the pressure here should be less, so the air will get in. Very simple. During exhalation, the pressure should be high here, so the gas will get out. Right? And the difference is what? Just 1 millimeter up, then 760, and 1 millimeter less than 760. Yes.
So it's 759 right before you inhale.
Yes. Yes. Then the gas will start to get
At
in.
the initiation of the inhale. But once you completed inhaling,
It comes equal.
okay,
Okay. Then during exhalation, the pressure will start to go up inside the lung.
wouldn't it be higher before you exhale, and as you exhale it gets lower, right?
It happens at the same time. The pressure increases and the gas gets out. So it is not like first the pressure will go up and the gas will get out. The pressure will increase and the gas will start to get out. That increase reaches to the peak 1 millimeter. Okay. So it is not like first the pressure will go completely all the way down. No, it's like your lung is expanding slowly, your lung is contracting slowly, right? So pressure is changing during that. Okay? But to initiate, it will start to go down a little bit. To initiate that, it will go down slightly. Anyway, so just know that the gas will, few things only. The gas will move from high to low. Okay? So atmospheric pressure is 760. So for the air to get inside the lung your pressure should go 1 millimeter below 760. Make sense? And to exhale, the pressure inside the lung should be more or high? More. Okay? 1 millimeter more. And that 1 millimeter is enough to take the air inside or exhale the air to the outside. Slight difference will move the gas from one compartment to another. And interpleural pressure is always what? Negative. To keep the lung what? Expanded. To keep the lung expanded, we need negative pressure here, outside of the lung. Very simple. If the pressure is high here, that will press the lung and lung will collapse. Right? To keep it expanded, we need negative pressure. And that is 756 millimeter of mercury. So, which pressure, if I ask you which pressure is not fixed? Interpulmonary is not fixed because it is changing, going a little bit up and down, right? Which two are fixed? The atmospheric pressure is fixed, right? We are not changing the atmospheric pressure during breathing, right? Atmospheric pressure is what? 760, it is fixed. Interpleural pressure is 756, which is fixed. It needs to be fixed because it will keep the lung expanded all the time. Yes?
On the slide before this, it says under pleural pressure that it fluctuates with breathing.
Interpleural pressure, it says that? Okay, so that statement is not correct. Only, that is always fixed. Remember that negative pressure is always fixed. That should keep the lung expanded. Only the interpulmonary or interalveolar pressure changes. Okay?
So say it one more time. Which statement's wrong?
The interpleural pressure is fluctuating. No, it will always remain same.
Okay, so the middle one is.
Only the pressure will change is interpulmonary or interalveolar. Same thing. Okay? Now, you can say, what I can tell why they said it is fluctuating. You see here. This pressure, interpleural pressure is what? 756, right? Interpleural is 756. Now, here is changing, right? Here is changing, interpulmonary. Now, if just see why they said that it is fluctuating, but actually it is not fluctuating. Here, it could be during inhalation, it is 759, right? During inhalation, it is 1 millimeter less. So now, what is the difference here? What's the difference? 3. 3 millimeter, right? That means here, now if I say inside the interpleural pressure is how much less? 3 millimeter, right? So negative 3. Make sense? Negative 3. Now, during exhalation, interpulmonary pressure goes up, right? To this. Now if I ask you, what is the difference? -5. Now we can say that it changes from -3 to -5, right? But actually, it is not changing. Does it make sense? So, interpleural pressure is fixed. Fixed means 756. Make sense? But relatively, you can say it is going up and down, but actually not. compared to the interpulmonary. Okay, now inspiration. Why inside the lung the pressure goes down? What is the mechanism? When the inspiratory muscles contract, okay, in the wall of your thorax you have intercostal muscles in between the ribs, intercostal muscles. So when these muscles contract, what happens? Your ribs move forward and slightly upward like this, forward and upward when the inspiratory muscles in the wall of the thorax contract. And when the diaphragm contracts, diaphragm goes down. Okay? So now we see what happens. This is your lung. This is your lung, and this is the wall of your chest, thoracic wall, and here is the diaphragm, you know that, diaphragm. And you have the pleura here. So when the intercostal muscles, inspiratory muscles contract, your ribs move what way? Forward and slightly upward. This way, forward and slightly upward. So the lung will expand that way, anterior posteriorly. The lung will get bigger because when the chest wall will move forward and upward, the lung will move that way. And when the diaphragm contracts, diaphragm moves downwards. So since the base of the lung is attached to the diaphragm will pull the bottom of the lung downwards. So the lung will increase, the diameter will increase superior inferiorly. So intercostal muscle contraction will increase the diameter of the lung anterior posteriorly, and contraction of the lung will move the bottom of the lung downwards. So this way the lung will expand. So the lung will expand this way, anterior posteriorly as well as superior inferiorly. So inside the lung, the volume will increase. Make sense? So when inside the lung, the volume will increase, the pressure inside the lung will go up or down? Will go down. Remember, same amount of air. Think that same amount of air inside the lung. Now you are just making the lung bigger. So the pressure of air inside the lung will go down. Because if you put same amount of air into two containers, one is big, another is small, then the pressure of gas will be more in the smaller container. Okay? Make sense? So when your lung is expanding anterior posteriorly, superior inferiorly, the volume inside the lung will increase. Make sense? So that will create negative pressure inside the lung. So the negative pressure means the pressure will go down. So the gas will go in from the outside. Okay? So expansion of the lung will decrease the interpulmonary pressure to 759, and that will let the air get in. Okay, so that is the inspiration, which is an active process because we are causing the contraction of the muscles actively. Muscle contraction is an active process. We need energy to contract the muscle. Now, what will happen during expiration? Expiration is a passive process. That means when your inspiration will be completed, you have taken air inside the lung, gas exchange will occur, then you will exhale the air out. What will let the gas out? First, those inspiratory muscles will relax. So your thoracic case will go down because the muscle will come back to its actual previous condition. So relaxed condition. So the thoracic case that moved forward and upward, that will come back to its previous position. So that will decrease the anterior posterior diameter of the lung, and the diaphragm will move up. The diaphragm muscle will contract, so diaphragm will move up. So that will bring the superior inferior diameter back to normal. And number 3, the elastic property of the lung tissue. The lung is an elastic organ. It has a lot of elasticity. So when you expand something that has a lot of elasticity, when you will release that pressure, it will come back to its actual shape, right? Actual position. So those three things. One is relaxation of your intercostal muscles, relaxation of your diaphragm, and the elastic property of the lung tissue. All those things together will bring the lung back to its previous shape. Now, when the lung will get smaller, the pressure inside the lung will increase. Make sense? That's simple. The pressure inside the lung will increase, and that will let the air get out. Increase means what? 761 millimeter of mercury. Make sense? So it will go a little bit above the atmospheric pressure. Atmospheric pressure is 760. It will go to 761. That will move the air out. Okay. So that is a passive process. Now, if I ask you that inspiration is active or passive? Inspiration is active, right? You are contracting your muscles. You are contracting your diaphragm, you are contracting your intercostal muscles. So active process. And expiration is passive because the muscle is, after contraction, it will automatically come back to its relaxed previous condition. Now, if I ask you forceful expiration, if I ask you to exhale the air forcefully, then it is no more a passive process because you have to use your expiratory muscles, your abdominal muscles. You can try. If I ask you to forcefully exhale the air, you have to contract your abdominal muscles as well as thoracic muscles, right? You have to. So forceful expiration is an active process. Okay? And forceful expiration requires the activation of both thoracic and abdominal muscles as well. And you know that when you do exercise, forceful inhalation, exhalation, you use the abdominal muscles too, right? You all know that. Surfactant. Surfactant is a fluid secreted by surfactant secreting cells, type 2 alveolar cells. The wall of the alveoli, you have seen the surfactant secreting cells. Those cells will secrete the surfactant. And that fluid lies in the inner surface of the wall of the alveolus. So this is the wall of the alveolus, and in the inner surface you have that fluid attached. That fluid is called surfactant. Okay, surfactant. And just know that surfactant is essential to keep the alveoli expanded or open. If the surfactant is not present, the alveoli will collapse. Okay, will collapse. So surfactant keeps the alveoli open, expanded. Otherwise, your alveoli will collapse. No air will get in. Okay, so it's like the balloon, expanded balloon. And if you let the air get out, then it will squeeze, right? So if surfactant is not present in the wall, the alveoli will not stay open. Yes.
How come the lung isn't more like a balloon? It's like the opposite of a balloon. Isn't it kind of like the way the pressure changes? It's like the opposite.
Which way?
I don't know, like, you said that when the lung is expanded, the pressure inside of it is less, right?
When the lung expands, then the pressure inside goes down.
Yeah.
Yes. This is very simple. Like if you have two just think that you have two tires in your car, okay? One is this, another is this. This one has 500 liter, just example, or 50 liter air, okay? And this one, same volume, has 30 liter air. The pressure inside this one will be more. That is simple, right? Pressure inside this will be more than this because the volume is same. Inside the same volume, if you put less air in one, more air in one, then the pressure of gas will be more in this one, right? So when you're now, let's do this way. Both has 50 liter. Now if, and same size. Now if you increase the size of this one, then the pressure will be less here. Okay? So the same amount of air, but in more space.
Okay,
So
so
the
when
pressure
it's
will-
smaller, there's more
Pressure will-
pressure.
Yeah,
Got
right.
it.
Yeah. Okay? So
Yeah.
you are expanding the lung, but inside the lung, the gas is same amount. So the pressure will go down.
Okay.
And that will let the air to get in from outside. Okay.
I don't know why that was so hard to understand.
Yeah, this is very.
I think it's just the numbers, really.
Yeah. Need to think simply. Sometimes you think too complicated. That's all. Okay, so there is a clinical condition that happens in infants that is called infant respiratory distress syndrome. Infant respiratory distress syndrome, or it is there, IRDS. Have you heard that? Infant respiratory distress syndrome. That happens in infants due to the absence of surfactant. And absence of surfactant is due to absence of surfactant secreting cells in the alveoli. If in your alveoli you don't have surfactant secreting type 2 cells, then surfactant will not be secreted, right? So surfactant will not be present in the alveoli. So the alveoli will do what? What is the function of surfactant? Will keep the alveoli open, right? So if that surfactant is absent, then your alveoli will collapse. So all alveoli will collapse. So your lung will collapse. Make sense? Because lung is filled with alveoli. So if all alveoli collapse, then the lung will collapse, will get small. Air will not be able to get in. Yes.
So is surfactant a liquid?
It is a fluid. Yes, it is a liquid. Yeah, thick liquid. Okay, not like water. Very thick. Kind of. Yeah, that kind, but different component. Okay, so genetically, some infants may not get surfactant secreting cells or type 2 cells in their lung, in their alveolar wall. So in that case, their alveoli will not stay open, will collapse, and the air will not get in. Usually the kids die if they are absent. Now, in some premature delivery, what happens? The surfactant secreting cells grow or appear in the lung in the late part of pregnancy. Okay? Late part of the pregnancy. So, if the delivery is premature or early delivery, then there is a possibility that the surfactant secreting cells will be produced because the baby was born earlier. Okay? In that case, if you can take care of the baby for a while, then when the surfactant secreting cells will grow, will be formed, then the baby will start to breathe normally. Okay. That case is, in that case, you can, the infant or baby can survive. Now, if they are absent genetically, it will never be formed, produced in the lung. Yes.
And so those are the children that often go on ventilators, correct?
Second?
Are those the babies that would then go on like respirators and ventilators?
You have to overcome that critical period. You have to just past that critical period, take care of the baby during that critical period when the surfactant secreting cells are being produced. Then when they will be produced, then they will start to secrete surfactant, right?
So it's forcing the air in and out as oxygen goes, but as far as the alveoli, they're still collapsed at that point.
In those, it depends how, in most of the cases, in those kids, some surfactant secreting cells are already there. A small amount of surfactant is there, so it's not completely collapsed. If it is completely collapsed, then it's difficult. That's why most of the kids die. Most of the infants, they die. Okay? It depends on the severity of, like someone could have 30% surfactant, 70% will grow later, right? Someone might not have less than that.
Nothing measured? Is there a test?
No, you can just see the condition of the lung. You can do that actually. But yeah, by the imaging technique, you can see how the alveoli are expanded or the lung is expanded. You can measure that.